NST, it is the method of antenatal fetal surveillance in which the fetal heart rate monitoring will be done on a graph in antenatal period when there is no contraction or stress. Hence, it is known as non-stress test. When this non-stress test, when there will be contractions or if NST is non-reassuring, then we will do contraction stress test to assess the uteroplacental insufficiency. It will be done by the same machine, but oxytocin will be given or nipple stimulation for uterine contractions. Cardiolocography is having the high sensitivity, that means it is good at diagnosing the fetuses which are good. Possibility of the baby having the hypoxia is very less when the CTG is reactive, whereas it will have the low specificity, that means it is poor at identifying the fetuses which are unwell. It doesn't mean that the baby which is having non-reactive CTG will always be hypoxic. Then coming to CTG machine. CTG machine consists of monitor, Doppler probe for FHS localization, Toco probe for uterine contractions, and paper roller. For CTG tracing. After localizing the FHS, this Doppler probe is placed this FHS will be recorded in this CTG paper in print as well. Toco probe should be placed over the fundus of the uterus. The Toco probe will be placed over the fundus of the uterus. That will record the maternal uterine contraction. This CTG paper will have the fetal part and maternal. In fetal, on x-axis there will be FHS, and on y-axis there will be time. In maternal part, it records the maternal uterine contractions. Coming to CTG paper, it will have fetal part and the maternal part. Fetal part, the vertical axis will show the fetal heart rate. CTG paper will have fetal part and the maternal part. In fetal part, heart rate will be recorded on the vertical axis and time on the horizontal axis. The heart rate is will be in the multiples of 30s or 20s. In this CTG paper, it is in 30s. This green shade will show the normal heart rate. Normal range of the fetal heart rate, that is between 110 to 160. Fetal movement will be marked as dark arrow on the CTG paper. Coming to maternal part, it will record the maternal uterine contractions. Usually Toco probe will be fixed to 20. Number of contractions can be calculated. The strength of the contraction is not important in CTG. It is the number of contractions which is important. Usually CTG paper reading will be set at 1 centimeter per minute, but it can be set at 2 centimeter per minute or 3 centimeter per minute. When it is 1 centimeter per minute, then each small box will be of 30 seconds. In 2 centimeter per minute, this small box will be of 20 seconds. When it is 3 centimeters per minute, then this small box is of 10 seconds. When we see the ECG, CTG reading, then in 1 centimeter, bit to bit variability will be good. In 3 centimeter, it will look like bit to bit variability is reduced. So we have to look the CTG paper. Therefore, we have to look for CTG paper reading before interpreting the CTG interpretation can be done by using the mnemonic. First is define the risk, like maternal risk or any obstetric risk, like in preeclampsia or multifetal gestation, RH incompatibility, or maternal like Kapla syndrome and all. C is for contraction, to look for contraction. Then BR is for baseline rate. A is for acceleration. B is for bit to bit variability. D is for deceleration, and it is the overall impression. First we have to look for the baseline rate, that is baseline rate should be between 110 to 160. If it is less than 110, it is known as fetal bradycardia. If it is more than 160, it is tachycardia. Baseline heart rate will be taken by seeing the CTG. Should be the CTG paper should be read for 2 minutes, and most horizontal part is taken. In this CTG, it is about 145 beats per minute. Then coming to bit to bit variability, if it no bit to bit variability, then it will look like straight line. If minimal bit to bit variability, that means the less than 5 beats per minute. Moderate bit to bit variability, that is normal, 6 to 25. It will look like this. It will be between 6 to 25. It is normal. Then marked bit to bit variability, that means more than 25 beats per minute. One small box is of 10 beats per minute, that means this. It is marked bit to bit variability, that is abnormal. Another is the sinusoidal pattern, that is smooth undulating pattern with no bit to bit variability. This is seen in fetal anemia and fetal hypoxia. Third component is acceleration. Acceleration means the heart rate should rise by more than 15 beats per minute and last for more than 15 seconds. In more than 32 weeks baby, in more than 32 weeks gestational age, if it is less than 32 weeks gestational age, then it will be taken as 10 beats per minute, more than 10 beats per minute, lasting for more than 10 seconds. If 2 or equal to or more acceleration in 20 to 40 minutes, then it is reactive NST. That means the baby is oxygenated. Acceleration, it is the marker of the autonomic nervous system of the baby. Then coming to deceleration, similar to acceleration, deceleration is also the decrease in the fetal heart rate more than 15 seconds, more than 15 beats per minute from the baseline, lasting for more than 15 seconds. If it is single deceleration, it doesn't have any significance. If it is more or equal to 3 times in 20 minutes or lasting for more than 1 minute, it is significant. Then we have to do the contraction stress test. Coming to types of deceleration, when deceleration will have the beat to beat variability, then it is the good sign. If deceleration will have the shouldering, that means acceleration before deceleration, then dip, that is known as shouldering. After coming to baseline, if it will get have one acceleration, that means the overshooting, shouldering, and beat to beat variability in deceleration, it is the good sign. This is peak point of deceleration, it is known as nadir. From baseline to nadir, it will take more or equal to 30 seconds, and this deceleration will coincide with this nadir will coincide with the peak of uterine maternal contraction. Starts with the dip will start with the maternal contraction, maximum contraction, then the dip will be maximum, and it will return to baseline when uterine contraction subsides. This is known as early deceleration. It is due to head compression. It is not pathological as the patient baby will get descend head compression, that will lead to early deceleration. Late deceleration is the second type of deceleration, in which after subsiding of contraction, the dip continues and return to normal after some time. The baseline heart rate to the nadir, it will take more or equal to 30 seconds. It is gradual. It is known as late deceleration, and it is seen in uteroplacental insufficiency, and it is pathological. Third type of deceleration is the variable deceleration. Depth and timing is variable. It will be abrupt. It won't take the 30 seconds, it will take less than 30 seconds. Usually it will take 30 seconds from the baseline up to the nadir. It will take 30 seconds. In variable deceleration, it is abrupt in onset, take less than 30 seconds, and it does not coincide with the maternal contraction, and it is seen in the cord prolapse or cord compression. When the deceleration is last for more than 2 minutes, it is known as prolonged deceleration. And when this deceleration lasts more than 10 minutes, acceleration or deceleration which will last for more than 10 minutes, then it is known as baseline shift. Now this is not the baseline, this will be the baseline heart rate. When there is sudden abrupt bradycardia and it will last for longer time, and there will be shift in the baseline heart rate, usually this type of CTG is seen in cord prolapse, uterine abruptio placenta, and also the uterine rupture. This type of CTG is seen in the chronic hypoxia, where there will be less beat to beat variability, that is less than 5 seconds. In subacute hypoxia, there will be deceleration and it will return to baseline, but it will go back and another deceleration that is known as straight and then straight line, and this will be less than 30 seconds. This baseline will be less than 30 seconds. It is known as stair step to heaven. It will be seen in subacute hypoxia. Another is the lambda, that means acceleration followed by deceleration. It doesn't have any significant role.